All right, y'all. Good evening. Good evening. Yours truly, Dr. Pierre, bringing you another special episode of the Real Physician Reacts. This is our weekly live series where I come on here and talk about something that I think is very important that comes across my timeline. So if you're watching me live, first of all, I appreciate you. Make sure you hit the like. Make sure you send some hearts out. We appreciate you. Those who catch this on the podcast, whenever you catch this on the podcast, I suggest you hop over here on TikTok where we go live and discuss these things. So now, this is some news that kind of came out within the past week. Unfortunately, when it came out, your friend was ill, right? Yes, doctors can get sick as well. This time, the culprit wasn't even like a regular patient. It was actually my mom. I was taking care of my mom. She came down with some illness. Of course, I did what sons do, took good care of her. And probably like 3 days later, those same symptoms she had, I got, right? Like lost voice. I was down in bed for probably like a day and a half. Y'all know doctors work a lot. So I was back at work on Monday. Whole different discussion. But we are here to talk about some important news, especially for a patient population that I've discussed here on the lives, on my podcast, on my blogs for the better part of like a decade now, which is our patients with sickle cell disease. And I've talked a lot about sickle cell patients and the scrutiny, the persecution. I don't want to say persecution, but that's a strong word, but like just the ill presence and ill kind of care that they would receive because they were sickling patients, because they were coming to the hospital dealing with these chronic issues, and it mentions kind of these vaso-occlusive issues. But we just typically call it like a sickle cell crisis, right? Like that is what they've been dealing with. And I've taken care of lots of patients over the decade that I've been out doing medicine as an attending physician. And I don't have sickle cell disease, but I've had friends and family members with sickle cell disease, and I understand the plight of going to the hospital, saying you're in pain, and someone not believing you. Like there's plenty of studies out here, especially for Black folks, right? Plenty of studies out here that talk about this aspect of people not believing you when you are in pain. And no population faces that more. No population faces that more than our sickler patients. So when this news comes across my feed, right, FDA approved sickle cell treatments, including one that uses CRISPR, right, my eyes light up. One, for the technology. Y'all know me, especially if you've been following me. I'm a big technology buff, especially when it comes to healthcare. I think a lot of times people will take for granted that we can have technological advances when it comes to, our cell phones, when it comes to our computers, when it comes to our cameras. But for some reason, they don't think those technological advances will end up in medicine. And I love seeing when technology and medicine marry together and have, produce such a beautiful baby. So genetic medicine is the next frontier of the type of medicine that we are going to get to. And we're not going to dive deep into it tonight because that's a whole different discussion that, for some reason, it draws people on opposite sides. We're just going to be talking about the people who are going to be helped with news like this. So what's happening? FDA approved 2 new treatments. The first one, I want to make sure I got their names correct. Casgevy. The next name is Lyfgenia. I apologize if you're a part of that company and I pronounced that name wrong. Both are 2 remedies, gene therapy remedies for patients with sickle cell disease. And what is the problem with sickle cell disease? We'll do a quick little education. What is the problem with sickle cell disease? Sickle cell disease is a genetic disorder that causes our blood cells to sickle. Like it actually sickles. If you know what a sickle means, it's like the moon shape. It causes the sickle. The unfortunate problem when it sickles is that it gets stuck in our blood vessels and causes pain and causes the inability of blood flow and oxygen to pass. So what happens, right, and we've talked about this in the past, what happens when you have a lack of blood flow? When you have a lack of blood flow in the heart, we call it a heart attack. When you have a lack of blood flow in the brain, we call it a stroke. So imagine you having a genetic disorder that precludes you to have lack of blood flow to multiple areas of the body, including the kidneys, the spleen, the heart, the brain, the legs, every organ you can think of. There's going to be an issue where you're having a lack of blood flow due to these sickling cells. And it only gets worse. And it's not like something that gets better when you're, older. No, it only gets worse the older you get. And you'd be surprised the amount of patients, especially teenage to young adult patients with sickle cell disease who already don't have a spleen. I want you to think about that. They lost a spleen by the time they're a young adult. And the reason why is because the spleen is, I like to call the spleen almost like our garbage collector, right? Our spleen does a good job at picking out the impurities in our blood and getting rid of them. But the problem is when your whole cellular line of blood is dealt with impurities, the spleen overworks itself. And then because of how sickle cell disease is, you have lack of blood flow, and then it actually infarcts on itself. So the spleen actually infarcts, actually dies on itself from being overworked to the sickle cell disease. So that's, again, and from a patient perspective, right? So because you guys don't need to necessarily know the clinical aspect of it. From a patient perspective, what does that mean? You have a patient who are, again, typically African-American or Asian American or Asian descent. You typically have a patient who ends up in the hospital for multiple issues associated with sickling crisis, whether it be due to intense pain, whether it be due to the infarcted organs, illnesses just in general, pneumonia, flu, like whatever the thing is, it's severely affected with our sickling patients. And what typically occurs is because the pain is so great. If you know anyone who has sickle cell disease, ask them to try to describe what that pain feels like. They just don't know. They just say their body hurts everywhere. And a lot of times it gets localized. So a lot of times maybe their arm hurts, maybe their leg hurts, maybe their back hurts. And there's really nothing they can do. There's no position. There's no water. Like there's nothing that they can do to try to prevent this. So it gets to the point, and what I love my hematologists, oncologist doctors for this, is that they try to manage the pain on an outpatient basis, right? They try to give you pills to deal with the pain, till the discomfort, until you can't no more. And then you end up in a hospital. And because of I like to blame, I don't like to blame, but it's kind of true. Because of the opioid epidemic, right, that actually destroyed this country, right, it continues to cause us problems. You now have a class of healthcare professionals who don't believe, right, like that you're in the type of pain that you're in. Why? Because when I run, there's labs that I run and all of your labs look normal. What do you mean you're in such intense pain? Like, no, your heart rate's fine. What do you mean you're in such intense pain? Because these are people, sickle patients. If you talk to sickle cell patients, they will tell you that they're always in pain. Like, who is it? Bruce Banner, right? When he talks about again, if you're a Marvel fan, right? Where he talks about no, I'm always angry, right? Like sickle cell patients are always in pain. What tends to happen is this pain enough that I need to sit down somewhere for a day? Is this pain enough that I need to go to the hospital? That's what typically happens. So it's not as they go, 4 weeks, 1 month, no pain whatsoever. It's just that they're always in pain, but they kind of deal with it. They kind of deal with the discomfort until they can't deal with it no more. So then they run to a healthcare system that's supposed to be taking care of them, and they do nothing of the sort. And I've said this before, unfortunately. And again, because I've been the hospitalist physician who's had to convince other hospitalist doctors, like, hey, you know what? Just give them pain medication. What are we doing here? Like, what are we doing here? Like, even if, right? I always give my docs and my medical students the benefit of the doubt, right? Or residents benefit of the doubt. I say, all right, let's say they're pain seeking, right? Let's say that's the issue that they have. Like, what are we going to do about it? We're hospitalist doctors. If a person is coming here to say, hey, I'm dealing with some discomfort, I'm dealing with some pain, like, we got to do what we have to do. Like, so for us to try to change, right, this matter now, it doesn't make any sense in the world, right? Like, take care of the pain. Like, and pain is such a significant issue where we think that a person in pain has to have a high heart rate, all these other things here. But again, when you always live in pain, your blood pressure could be normal. When you always live in pain, your labs can be normal, but you're just dealing with the pain. You're just dealing with these crises because again, there's not great lab tests that show, oh yeah, this person is in a sickle cell crisis, right? Someone said it like the localization of pain is just normal. It's normal. Like they just like, all right, yep, it just is what it is. I'm going to have this pain today. And I've had patients who have gone to multiple hospitals just to be admitted to deal with their pain. Multiple hospitals, right? I got plenty of stories for you, right? I won't bog it down now, but there's plenty of stories where these patients are coming to our system of care and not feeling loved, not feeling cared for, and feeling shunned away. So when I see this article right here that says, hey, this a new treatment, right, that could possibly take that feeling away from them, like I'm jumping for joy, right? Now, of course, there's some questions. We got some questions. And I know, because I know how everyone's thinking, right? When you have the sickle cell crisis, right? And now you have these treatment options. What goes on? What is happening with these treatment options? And more importantly, what the process, right? Because it's not like, hey, I take this pill and I'm on my way. Unfortunately, it is not. Because what has to happen in a general layman's type of form is that they have to take our original blood cells, our sickle cell patients, right? They have to take our blood cells from the sickle cell patients and then, again, edit them, right? And again, it sounds sci-fi, but I love it, right? Edit them so now that it stops making those sickling blood cells, right? They have to do that. And there's a couple things that happen, right? That, obviously they gotta get your blood cells, right? That's one, right? They have to get your blood cells to do so. Right? And then they essentially have to give you like chemotherapy to knock down everything that's in your system, right? Why? Because once they take your original blood cells and then they do what they need to do with these new medications here, right? Casgevy and Jenny, right? Then they have to put it back in your body, right? But they can't put it back in your body if the old cells are still lying around. So they have to get rid of all the old cells. So this is not a quick process, to say the least, right? This is not a quick process. And more importantly, especially for my economically inclined folks on the timeline, this isn't a cheap process. So what does that mean to me, right? So what am I thinking about, right? When I see, all right, this is a process that's not quick and not cheap. How is the population who's likely going to benefit actually going to get this? That's my first question right off the rip, right? Like, how is and I'm biased, right? How is the African American population going to get this? One, like, how are they going to find facilities that can, draw their blood cells, keep them because you're going to be hospitalized and stay hospitalized while all of this process is happening. Draw the blood cells, give you chemotherapy, send it out to these people here to do the gene editing that needs to occur, and then give you back to you, right? Like how are they going to do all of these things here? And then who's going to foot the costs, right? So we got some questions right now, again, and these are valid questions because I know some people are thinking like, all right, like how, and I want us to have these questions in the back of our mind, but I want us to at least celebrate that there's an option out here. Because before, right, 6 months before this, there were no options. Right? When you had sickle cell disease, you were living with sickle cell disease. You were living with crises that may have had you hospitalized once every quarter, right? Think about that, 4 times a year having to be hospitalized because you're in so much pain. And once every quarter is great. I know some patients, they can do very well. And maybe it's only once every 6 months, right? So just twice a year. Right. So this is going to be life changing. And what the studies have shown, and I'm going to do some TikTok videos on the studies that went into it. What the studies have shown is that, and what they look for, right? Because it's always important. Like, what are they looking for? They say, hey, you know what? We're going to take this population of sickling patients who have had crises in the past year, at least 2 of them, which means you've had it frequently. And then we're going to give you this treatment. And then we're going to monitor you for the next 2 years and see what happens. And what they found was a success rate. One study had 88% of the Casgevy, an 88% success rate of no more vaso-occlusive crisis, aka no more sickle cell crisis that ended up going in the hospital. That is life-changing. That is life-changing. Why? Because that means that now I can now avoid the thought of having to go to the hospital again. I can avoid the thought of having to be hospitalized because I'm in so much pain. A lot of people, unfortunately, will surmise to the constant sickling crisis, the constant infections associated with those sickling crises, and die early, right? Sickle cell patients typically have a lower life expectancy rate because of all of these crises affecting every organ, right? That's what happens. So now you have this treatment process. And like I said, I know we're thinking, all right, but who's going to pay for this? And where's it going to, like, those are valid questions. But I think right now, just having an option is such a significant milestone that I don't want the very obvious questions to kind of push down the news, right? I want us, and that's why I wanted this live to be a little bit more patient focused, right? I want us to think about, infections are crazy. Yes, because they typically have, someone in the comments said the infections are crazy. Yes, typically our sickling patients deal with pneumonia. They deal with any type of viral infection, the flu, because, and again, this is just more, kind of putting two together. The spleen is a very important defensive organ in our body. Right, a lot of viral infections are thwarted because the spleen does what it does. But if you have sickle cell crisis and eventually you have an infarcted spleen that does not work no more, guess what? You are now more likely to deal with infections, especially of the viral nature. Right, this is a little microbiome discussion, but again, I think it's important to kind of put two and two together. Why patients with sickle cell disease also have these issues with infections. So they're susceptible to infections, and because they're always in the hospital, guess what? Guess who else is in the hospital? Sick people, right? So I'm coming in just to deal with my pain, but now I have to go in a building where there's a lot of sick people over there, right? And because I'm already immunocompromised in a sense, I have to deal with the possible effects that one of their illnesses can get on me, right? It just is what it is. That's the unfortunate. I can't. Someone says, who pays for it? Should it be insurance, Medicaid, Medicare? Shouldn't even be a question. See, that's a very good question. You guys are asking great questions. Who should be paying for this type of therapy? You know what I think is going to be important, right? I think what we're going to see, right? And again, I'm just spitballing now. I don't know, right? I think when we think about who should pay for this, you're going to see. All right, does the cost benefit of having our sickling patients continually going to the hospital, continuing to use up resources in the hospital, continuing to have infections and have a lower life expectancy, is it gonna cost us more, right, to treat them, or is it gonna cost us more to treat their sickle cell crisis and act like we don't have a possible treatment option? That's going to be that's a big medical ethics question that's going to come into play that I think is going to be extremely. I think it's definitely going to be debated about, because in this, I'm in the United States, y'all. In this country right here, we don't really helping out those in need. I'll just be honest. I will just be honest. We don't really helping out those in need. So now if you have a significant population that deals with a disorder that can't necessarily pay for a disorder and someone else may have to pay for it, right? You're going to have discussion. We'll just say that. You're going to have discussion from that standpoint there. But it's a very good question. If you ask me, I think you're going to get some type of subsidy that comes from the government in one way, shape, or form. That's going to help try to minimize some of that cost. Because again, like I said, I'm just spitballing what this is actually the process, but you have to be hospitalized so they can do the procedure to get your blood cells out, right? And it's a specific thing that but you have to be hospitalized to do that, which means hospital bills. Right. You then have to send that blood that you just got out that patient and send it to the CRISPR. What is it? What is this? CRISPR Therapeutics. Right. I got it on my screen over here. You got to send it over there. Then they got to do what they need to do with it right, to change it genetically so that when they send it back to you, like it's ready to go. So they have to do everything. Cost right there. Then when they send it back to you, guess what's going to happen? You got to get chemotherapy. The reason why you got to get chemotherapy is because you need to wipe out all of those old cell lines there so we can introduce new ones. Because if we don't do that, it's not going to work, right? So now, boom, that's another thing, right? All right, again, so I'm just telling you, the costs are piling. And then after they give you the new, gene therapy, right, you got to be monitored in the hospital, right, probably for another 4 to 6 weeks, right? Like, so there's cost, there's time, there's a lot of questions that need to be answered that's going to make it like readily available for the population who needs it. Like, I have a master's in public health. And one of the things my professors would always tell me, like, and they would make fun of, because we had a lot of medical students who are also getting a master's of public health in the same, I went to Nova at the same time. So my professors would make fun of us and saying, hey, you doctors, that's what they call us, you doctors, like you guys are like great at coming out with theories, but then we have to answer the question, how does it get to the actual population, right? So this is, again, in theory, right? Not even theory, this is now practice. Like we have a treatment option, right, to treat sickle cell disease. Like that's not a theory no more. We have it. Now, like in real life scenario, how do we get it to the population who can get it, who unfortunately couldn't just outright pay for it right off the bat without some support? And then who's going to do the support, right? These are just questions that my public health hat like goes on to say, this is interesting, right? This is great. But who's gonna pay for this, right? Like who? And I hate that I think like that, but I just know that wow, this is what we've been waiting for. We've been waiting for technology and medicine to catch up to treat some of these diseases. Like we saw the last disease that we had to face where we needed technology to come around and say, hey, I'm ready for you. And if those don't know what I'm referencing, I'm talking about COVID. And I'm talking about mRNA technology, right? Like we seen that come to light. And we saw the immense benefits of having mRNA technology in our vaccines. We didn't have that before. We got that now. And there's a whole bunch of options that are moving forward that is going to be might be scary to some people, but like I said, I'm jumping for joy of how we can use that technology for our vaccines and treatment. Now we have another thing. Now we're going to use gene therapy to treat diseases that are genetically embedded that's causing us problems. That would have been far-fetched 2 decades ago. When I was in medical school, you couldn't even like think about like, hey, you know what? You know, our sickle patients, how come we don't just do a process that removes the gene that causes sickling and then puts a good gene back? Like, and for adults, like we couldn't even fathom that. But it's here now. We're in 2023, going to 2024. It's here now. And because it's here now we're going to have to deal with the questions that are going to kind of arise from like now having technology. Right? Again, when mRNA technology came out, right, it was great, but there's a lot of people who had a lot of questions, right? Valid questions, right? We're not saying the questions they had for mRNA vaccines weren't valid, right? But you just needed people, right, like myself and others, right, who were able to answer them. Right now, we're gonna need people, right? Like, I don't even know what they call these type of doctors, right? Who deal with gene therapy. I don't know what type of scientists they are, but shout out to them. Shout out to them. We're gonna need them to be on the forefront to educate our community to say, hey, you know what? Like, this is why it's gonna be so important for us to buy in. Right, because especially, again, I'm biased because I know it affects the community that I take care of on a day-to-day basis. Someone said, if it requires chemo, doesn't that make those who get the treatment immunocompromised? Yeah, no. What happens, and that's a very good question, right? So someone says, if it requires chemotherapy, does that make those who get the treatment immunocompromised? Yes. And in fact, sickle cell patients are already immunocompromised. Like just in their disease process, because of the organ damage that the sickling process causes, they're already immunocompromised, right? There are already certain vaccines that a sickle cell patient can't get, especially if their spleen is gone, because of the fact that the spleen is gone. So they're already immunocompromised in and of itself. But to get the treatment option, which is a great question, Kim, to get that treatment option, we have to like wipe out all of the old blood cells. We have to wipe them all out. So we can then give you the new gene edited blood cells. Now they're your own. It's not like they came from, I was about to say not they came from that. They did come from that. It's not like they came out of nowhere. Like the first process is, hey, I'm going to take your old cells first. And what they do, which I think is smart, is that let's say they take your old cells and then let's say they take 100 of them. They sit 20 of them over here. Like, hey, we're going to sit this 20 over here just in case something, doesn't work. Then we could give you back your cells. So they do that. Very smart. So they take the 20, put it to the side just in case they need to. They take the 80 and then they send it up, right, to the gene labs to do the special therapy that needs to occur. And then they send it back to you when it's all said and done. But yes, it definitely will leave you immunocompromised. And that's why you have to stay in the hospital so long. So this is a process where you're in the hospital for a long period of time after you get the chemotherapy and then after you get the new cells, right? Because you don't want to have to run into anyone's new infection. You don't want to do, you have to avoid, like, for our patients, hopefully you guys aren't aware of it, but patients who come in and what we call neutropenic, right? So a lot of times I'm taking care of patients who are on chemotherapy, who are getting chemotherapy in the hospital setting. When we go in there, they get different food, they get different trays. When you go in, you're gowned up, gloved up, masked up, just like COVID. Like you are not only, and it's not because you're protecting yourself from getting something. You're protecting them by not giving them what you may have. So there's a whole wing of patients and there's a whole protocol of patients when the patient is immunocompromised in the hospital. So again, you need the right hospital setting. So someone mentioned earlier, what about the rural centers? That's a very good question. Like I said, you guys have amazing questions. And I think these are questions that have to be answered. And I'm very excited to see moving forward how my gene specialist, again, I don't even know, I apologize, I don't know what their specific title is of those types of scientists who do this, but I'm very excited to see how they're going to come online and educate us on how this is monumental. I could just from afar as an internist look and say, wow, this is going to be amazing. I'm just going to need them to kind of help bring us over the finish line because I know there's going to be a lot of people who have questions. There's going to be a lot of people who have family members and friends who have sickle cell disease, and they want to know, hey, can my friend get this treatment now? Can my family member get this treatment now? Is it too late for me now? There's going to be a lot of great questions that I know that there's people a lot smarter than me are going to be able to answer. So I'm just very excited. Like I said, that again, I wish I could have brought this to y'all last week, but your friend was sick. I was out. My mom got me sick, but that's okay. We're both better now. I got my voice. We're talking again. And of course, the second I get my voice, I'm gonna go live. I said we just gotta do this. We gotta go live, right? We gotta do it. We gotta educate our community. And I think this is a medical breakthrough. Just like mRNA vaccines were a medical breakthrough, this is right on the cusp. Because again, this is just the start. I don't even want to talk about other disease processes that we can treat with gene editing therapy. We're not even going to, trust me. Trust me, they're not stopping at sickle cell disease. I can 100% assure you that. That I can assure you. They're not going to stop at sickle cell disease with the gene editing therapy. Let me put because I know people call me capitalist. Some of my followers, they like to call me a capitalist, but I'm just a realist. And I recognize in medicine, they don't typically do things if money is not involved, right? So I know I'm putting my capitalist hat on and I say, oh, you know what? If they can do this with sickle cell disease, which again has a, finite population, imagine the diseases that they can do that has a bigger population, AKA a lot more money involved. It's happening. I'm pretty sure there's studies in the works now for that to occur. Right? Let me ask. I'm gonna answer a couple questions before we get up out of here. What about patients who bottom out during chemo and can't take no more? Oh, so this is a very good question. So what typically happens during chemotherapy is let's say boom, you get the chemotherapy, right? So because it's not like a prolonged process per se, right? It's not like for 4 weeks you're getting chemotherapy. Yeah, someone said it, type 1 diabetes, so you know it. A lot of cancers, you know it. Because that diabetes is definitely what I was thinking about. So let's say you're getting chemo, you might get chemotherapy for like 3 to 5 days, right? It may be a 3 to 5 day process of chemotherapy. But the thing is, all of the effects from that chemotherapy, you don't start feeling for like 2 to 3 weeks, which is why you have to stay in the hospital. Because some of the side effects from just chemotherapy in general, if you know someone who's on chemotherapy, obviously weight loss, there's a lot of hemoglobin issues, blood related issues, because all your counts drop, your white count, your platelet count, your hemoglobin, all of those counts drop. Again, you become more susceptible to infections, right? Nausea, vomiting, a lot of these things happen, but they don't happen while you're getting the chemotherapy. It's the sequelae of after you get said chemotherapy, which is why they typically stay in the hospital. So usually, you get that 1 weeker. You're not feeling symptoms from the 1 weeker. You're feeling symptoms for the next 2 to 4 weeks for the thing that you got in that first week. So that's the typical symptom process from it. And the reason why they do that is that they have to wipe out all of those old cellular lines. They have to get them out of there. Because once they get them out of there, then they can introduce the new genetically modified cells in your body that says, hey, you know what? These are some new ones. And now that you have these new ones, guess what? You're not going to make those sickle cells anymore. Guess what? You're not going to have to deal with those crises anymore. You're not going to have to deal with the pain and discomfort that you were dealing with anymore. You may have some old pain, but that may be old sequelae effects from it of prior to, but it's not going to be new, right? So that's what's happening, right, for these patients here, right? Just amazing results that we're seeing here. And when they answer those questions, which a lot of you guys had the great questions. When they answer those questions, all right, how is it getting to the people it needs to get to? And who's paying for it? When they answer those questions and are able to really, I don't want to say mass produce it, but get it to a level where the population who really needs to get it is able to get it, it's going to do wonders, right? And again, someone mentioned the type 1 diabetes. Once they do that, they're going to the next one. They're going to the next disease and then the next disease. And again, there's some people who are probably scared, itless, right? Scared, right? Because now, oh my God, they're going to do gene therapy and we're going to be walking zombies. I know that. I know. Trust me, I know. I have plenty of my conspiracy theorists in my office, in my practice, in my hospital. I know what that other side is already thinking. They don't want no discussion about gene editing therapy. Same people who did not want us to even deal with mRNA vaccines because they thought if they thought mRNA vaccines was gene editing, when you're actually dealing with gene editing therapy, what do you think those same people are thinking about right now? They want no parts of this, right? But, again, we will cross that bridge when we need to cross that bridge. We'll have that discussion when we need to have that discussion. But again, I'm just excited for the news. I'm excited. Someone said, I'm grateful for this treatment option. Yes, I am. Extremely grateful for this treatment option as well, too. Oh, yeah. Pediatric nurse, my most hated disease. Yeah. No, if you take care of kids, and fortunately, I'm an intern. I hate to say fortunately, I'm an internist, right? So if you're 18 and above, I got you. 18 and younger, I don't want nothing to do with you. I'll just be honest. I don't want nothing to do with you. But if you have taken care of people who just look in pain, just look uncomfortable, and are looking at you like, hey, I'm in pain. I know it don't look it, but I really am hurting right here. And the reason why it's so bad in the hospital, because let's say, I know a lot of people I know people are familiar with Percocet. Let's say Percocet. Let's say, your typical patient who comes in with some pain, discomfort is asking for one Percocet, right? Your sickling patient, after years and years and years of dealing with pain, they're not asking for the equivalent of one Percocet. They're asking for the equivalent of 8 Percocets, right, in an IV formulation. And you're looking at this, it could be a little bitty person because they're usually kids, right? A little bitty person, skinny person. And you're like, there's no way I'm giving you, 8 Percocets, which is like, let's just call it Dilaudid, right? There's no way I'm giving you that, right? Because that's what you're thinking. You're like, because if I give my, mind you, I had to get my wisdom teeth taken out. And the doctor gave me a Percocet and I was drooling over myself. And I was just like, how are people doing this? Like people are taking more than, I didn't know what to do with that, right? So, but the sickling patient who is usually a child, can eat those Percocets like it's candy. And you think that they're pain seeking, but the fortunate problem is that their body is so used to it that one Percocet does absolutely nothing for them. 2 Percocets, absolutely nothing for them. They need 4, they need 6, they need 8. They need IV medication, right, to get in their system if they want to deal with any of the pain. Right, that's some of the biggest issue and the gripe that our sickle cell patients have when they go to the hospital is because no one believes that they're in the type of pain that they're in. No one believes it. They're like, no, you're too small. You don't need that much pain medication. I'm only giving you this much. So then they sit there in a hospital for days under treated. And then someone says oh, you've been here for 2 days. You're good to go home now. And then they boot them out. Again, I wish I was being hyperbolous with how it typically goes. But if you ask one of your sickle cell friends or family members, how does it go when you're in a hospital? That's kind of the story a lot of them will give you. That's unfortunate, right? And generally said my brother-in-law died from sickle cell. Yeah, no, I had a cousin who died from sickle cell as well too, right? And just the complications from it. And what was unfortunate, right? What was unfortunate that you had people saying, you know what? He's no longer in pain anymore. Think about that, right? Your family member, friend dies. And one of your thoughts is, you know what? He's no longer in pain anymore. This is the life of our sickle patient, right? This is what they're having to deal with, right? In the general, this is what they walk around with. So this therapy, this news is going to be heaven sent, especially once they do whatever they need to do to get it to the people who need it. Because it can't be like Ozempic, right? It can't be like Ozempic where the only people who can afford $1,000 medication gets it, right? They're going to have to figure out a way for the people who need to get that medication to get said medication. They're going to have to figure out, that's going to have to happen, right? Our government's going to step up hey, if I got to pay tax dollars, cool. I already pay tax dollars. Send it over there. Doesn't bother me one bit, right? If I know that means I'm going to see these patients in the hospital less because they're pain-free and they're able to live their life, go ahead, take my money. Not a problem, right? But again, we got some tough decisions. I understand it. Right, we're going to have some people who are going to come out against this specifically because it's gene therapy. And again, like I said, they were terrified of an mRNA vaccine that had nothing to do with gene therapy. They are definitely going to have a problem with something that specifically has to do with gene therapy. That's going to happen. That is going to happen. We just know it, right? But Plan B says, therapy, great, access to care limited. We are going to have to figure out how to answer that question. That's the $1 million question. Someone's going to get paid a lot of money to answer. Someone's going to get paid a lot of money to answer. How do we get this to the population that needs to get it? It's great therapy. Right, the way we were able to do mRNA vaccines and the way we were able to give it to as many people who could get it, and at this point it's billions of people have gotten an mRNA vaccine one way, shape, or form. The way we do that, we're gonna have to figure out how to do it with this. I'm excited. I'm very excited for what's to come. I know, like I said, people who get paid a lot more than me are thinking about how to answer that question. I am going to be following a lot of again, like I said, maybe they're geneticists, right? Because I was just thinking what to call the scientists. Maybe they're geneticists. I'm going to start following geneticists. Maybe if there's a geneticist on TikTok, I don't know. If there's a geneticist on TikTok, at them for me, right? So I can follow them, right? Because I'm going to be, I got some questions that I'm going to need them to answer, right? So again, y'all be blessed. Y'all have a great evening. Thank you for joining this week's live. Like I said, we do this every Thursday night, usually starting about 8:30, 9-ish, something around that time frame. And then I'll be dropping some videos throughout the week, just kind of following up on this amazing news Y'all be blessed. Have a great day. Make sure if you missed this, I will be dropping this on my podcast tomorrow. It will be on my YouTube page tomorrow as well, right? So you'll get to catch up to it all. Y'all be blessed. Make sure you hit the likes. Make sure you hit the follow. And y'all have a good one, guys.